very big center, as I've seen before. I'd like to talk about streamlining mapping in complex arrhythmia. This is my disclosure. I'd like to start with the omnipolar mapping system with high density grid catheter. Omnipolar, this is we use the unipolar or bipolar mapping in current our practice. There is a pros and cons to the unipolar and bipolar electrode. In case of regarding to the unipolar mapping, we can the catheter oriented unipolar is independent to catheter direction, but there we can get a defined local electrogram by unipolar system. Regarding the bipolar mapping, we get a very fine defined local electrogram, but it depends on the catheter direction. And bipolar mapping is very incorrect. So, but it take a time to map a 3D map. However, unipolar map system is composed of usually basically 16 electrodes and determined from a click, a triangular set of 3 electrodes. Electron was calculated all direction 360. The maximum voltage of potential was automatically selected. The benefit of omnipolar technology: bipolar electrode look in the one direction, but high degree wave solution look in the 2 direction. We can get a bit-to-bit information from the bipolar omnipolar technologies. It allows operators to direct a moving map to efficiently locate the source of or define pathway. We can get a more point or more higher point density with omnipolar technology. A triangular creeks allows for 36 points collected for just one freeze and save effectively 2 millimeter spares. Let me move on to the near field detection algorithm. It's a new new map type displaying a distribution of high frequency activity based on the peak frequency of each electrode. It allows us to discriminate area near field versus far field activity. Near field area displays in the white, and while the far field with low frequency areas displays in the dark gray or lead. This emphasis map is one of the new map type. Is the following cases displays on omnipolar voltage map with peak frequency overlaid and to shade out far field data. The signal and site of termination or area of critical isthmus is clearly be shown. This is the Tactiflex catheter. This is the only catheter with a flexible tip and contact force sensor, and it allows the high power short duration ablation. I'd like to share my case with you. First one is atypical atrial tachyarrhythmia. Before we find a 3D map or entrainment, we cannot know what the mechanism is. So we cannot sure has a mechanism of tachycardia is macro-entry or focal. So we can say just atrial tachyarrhythmia. He is 65 years old. 2021, persistent of atrial fibrillation was diagnosed. Unfortunately, during refractory to amiodarone. 2022, I tried catheter ablation for persistent atrial fibrillation. At the time, I do PV isolation and mitral isthmus line ablation. Unfortunately, a couple of months later, atrial flutter was occurred, and I do cardioversion and amiodarone. However, recently atrial flutter was recurrent. I plan to redo ablation. This is a 12-lead ECG of recurrence. We can clearly show the type of recurrence is atrial tachyarrhythmia, not atrial fibrillation. This is the electrogram during lead procedure. HRA represents for high RA around the right lateral wall of right atrium. CS represents for coronary sinus. It's from left atrium. Before IMAP, I tried to give early PAC to get a quick assess for mechanism of tachyarrhythmia. So I used to give early PAC from distal sinus, did not elicit the tachycardia. In addition, early PAC from the high RA did not elicit tachycardia as well. And next, I tried to get a 3D map with omnipolar high density grid catheter, and this is activation map, and this is a frequency map. This is emphasized map to shade out the far field signal. We can clearly show that there is a critical isthmus. This is a propagation map. We can clearly show me the mechanism of atrial tachycardia, atrial flutter, not atrial tachycardia with focal mechanism. The critical isthmus is located in the anterior part of the right side PV, pulmonary vein. This is emphasized map propagation. It can clearly show us the critical isthmus located in the anterior wall of the right side PV. We can find the diastolic potential in the anterior side of the pulmonary vein like this. So I tried to entrainment there. We can see we can get a comparable for post-pacing interval with the clinical cycle length of clinical tachycardia. So I tried to do ablation there, where are the critical isthmus. This is my protocol for redo ablation for atrial fibrillation. In case of de novo procedure for atrial fibrillation, I think there is a little debate for regarding to the straight stage of ablation. But in case of redo procedure, there is some debate. So I'd like to share my experience with you. And at first, I think the most important thing before the redo procedure is check the recurrence and what type of the recurrence. So it's atrial fibrillation or atrial tachycardia, paroxysmal or persistence. If the recurrence is atrial tachycardia, we need a map first, an activation map or entrainment, and give a premature atrial contraction. So after we've identified the mechanism of atrial tachycardia, we can try to ablation there. In addition, the recurrence as atrial fibrillation, I tried to identify the trigger site with high dose aldosterone and cardioversion. If I cannot find any clinical tachycardia or any trigger site, I consider the ethanol injection into the vein of Marshall. After that, I confirm the pulmonary vein isolation again and confirm the bidirectional block of the line again. Next case is Brugada substrate ablation. As you may know, Brugada syndrome is relatively popular in Korea and East Asia. As you can see, some case of some patient with Brugada is very stable without another catheter ablation. But such a case, he suffered from aborted sudden cardiac death, and I implanted ICD to 2018. For a couple of years, there is a appropriate shock several times. I tried to control with quinidine. But recently, he suffered from very frequent peripheral shock during very short time. So there is no option to ablate somewhere. This is a sinus EGG. We cannot find very definite type 1 Brugada syndrome ECG. But I infused the flecainide to provocate the Brugada ECG. We can clearly see the type 1 Brugada ECG. Just after the provocation, I tried to map. I input the catheter into the epicardium to detect such a delayed potential with high density grid catheter. This is a map to find rate potential mapping on the epicardium especially around the right anterior part of the outflow tract. HD grid catheter can very easy to get identified such a delayed potential in case of Brugada syndrome. We can see the delayed potential around here. I try to ablate there, and we cannot found any delayed potential before the ablation on the epicardium. The last case is non-ischemic VT. As you may know, VT is much more difficult than atrial fibrillation, AF ablation, and non-ischemic VT is much more difficult than ischemic VT. He is 73 years old. He was diagnosed left ventricular lung compaction. Unfortunately, he suffered from sustained ventricular tachycardia. We tried to control with amiodarone and ICD, but he suffered from recurrent ICD shock. So there is no option to ablate for ventricular tachycardia. Ejection fraction is 35. This is a clinical. We luckily get a clinical VT before the ablation. This ECG clearly shows us the exit of the VTs came from left side and inferior part of the LV, and intrinsic deflection is relatively short. It means the exit is located in the endocardium rather than epicardium. This is activation map. Omnipolar technology clearly shows this area. We try to ablation on the critical isthmus on the apex. We can terminate the VT. Very luckily, no VT is induced anymore. This is my protocol for skull-related ventricular tachycardia. As I told you before, in the case of AF, I think it's very important to check clinical VT morphology possible, but it's not easy. High density map and very short map during the tachycardia is very helpful to identify the scar. I tried to induce ventricular tachycardia. If the hemodynamically stable, it's relatively easy, but I tried to get an activation map and entrainment to identify the critical isthmus. If the blood pressure is unstable, to a patient intolerant to ventricular tachycardia, I tried to find the line of block with functional map and ablation there, return to induced again. Thank you.